All right, Dr. Bikman, I appreciate you being with us today.
Hey, Ben, my pleasure. Please call me Ben.
Okay, all right, I'll address you as Ben. All right, so a little background. So I don't really remember when I first heard of you or when I first saw you. It may have been just some podcast interview you did or something like that. I've seen you on a couple different podcasts. But last year, I read your book called Why We Get Sick. And
Mhm.
that was really an awesome deep dive into insulin resistance and things like that. So it's obvious that you're truly an expert on the topic of insulin and probably a lot of other related things. But yeah, I really appreciate you being here because you've got a lot of insights to share, obviously.
My pleasure. Thanks.
So why don't you, just for anyone who's never heard of you or doesn't know anything about you, why don't you give just a short, kind of brief background about your experience and where you're coming from?
Yeah. I am a publishing scientist and research scientist and professor at Brigham Young University, and I am the director of the Diabetes Research Lab. And that is reflective of my overall interest in understanding metabolic health and disease, as type 2 diabetes represents maybe the most famous of the metabolic disorders. But my research focus, part of it, is to highlight the relevance of insulin in diseases. That while insulin is rightly viewed as a hormone that is essential to life, if we don't have it, we die. We, in most instances, suffer from far from a disease of a deficiency of insulin, but rather an excess. That the modern diet, in particular, what we eat and how often we eat it, is essentially creating a situation where insulin's constantly elevated. And part of my research focus, again, is to highlight how that's harmful, what it's doing to the body and to the cells of the body, and how that's driving various diseases.
Yeah, and so you said you had something called a diabetes research center there at
That's right.
BYU. Okay,
Yep.
yeah, and one of the things you mentioned in the book, which you just alluded to now, is that people often have too much insulin, and then you made a point in the book that most people don't know anything about this. Like, what is this insulin thing? What is this insulin resistance that we often refer to? Do you have kind of a way of explaining it that's kind of quick and dirty in like layman's
hmm
terminology or
hmm
something like that?
Oh, yeah. Ben, these are skills honed by teaching 150 20-year-olds every semester. So, yes. Yes, I have layman terms for everything. So, insulin resistance is a coin, if you will, and a coin has two sides, and it is absolutely essential that we understand both sides of this coin. Too often, we might only think of one. Specifically, one side of the coin is the fact that the hormone insulin isn't working the same way that it used to. It's certain cells of the body. And that last little addition is very, very important. So, some of the body's cells, like muscle cells, for example, don't respond to insulin as well as they used to. And this is reflected in higher glucose levels because one of insulin's effects at muscle cells would be to open the doors for glucose to come from the blood into the muscle, thereby lowering blood glucose. So, some of the cells aren't working, but some are working just fine, like the theca cells of the ovary, for example. Those cells of the ovary have perfect sensitivity to insulin, and they don't become insulin resistant. So insulin isn't working the right way at all of the cells of the body. And that's what we just call insulin resistance. But it's important to remember that it's not universal. It's not the entire body or every cell of the body. It's some of the cells. And that's very important when we flip the coin over. The other side of the coin is hyperinsulinemia, which is just a grand clinical term for high insulin levels. And that's very important. Anytime there is insulin resistance, there is high insulin levels in the blood. You cannot pull them apart. You cannot pick up the coin without picking up both sides. And so that matters because remember, there are some cells of the body that respond well to insulin, like the ovary, for example. And now the ovary is getting a lot of insulin and it's sensing it. And insulin has an effect on the ovaries, which is to inhibit the production of sex hormones. And in an ideal circumstance, when insulin is low, that's a very modest inhibition, and insulin doesn't really play much of a factor. But when insulin levels are high, like they are during insulin resistance, Now the ovaries are seeing too much insulin and they're responding too much to that insulin. And you have an inhibition of the production of sex hormones. And ultimately, then you have a woman who's suffering from the most common form of infertility in women, which is polycystic ovary syndrome, or PCOS. So again, brief review: insulin resistance is a coin with two sides. One side is insulin isn't working the same way that it used to throughout the body. And the other side is blood insulin levels are chronically higher than they used to be.
Yeah, yeah, and that's a really good explanation. And maybe we should have done even more just basic at the beginning. I know some listeners to this probably have like a science background, and maybe some don't. So insulin, of course. Correct me if I'm wrong on anything, but is a hormone that comes from the pancreas. Pancreas is an organ kind of right below the stomach, and it's maybe for a lot of people, it's kind of better known for secreting digestive enzymes that go into the gut, but then it
Mm-hmm.
also has another role of pumping out this insulin after a meal and other times, but mainly after a meal to kind of
Yep.
help process carbohydrates. So just for anyone that doesn't really even have like that, taking some biology classes in college type of background.
Yeah,
But
that's
what you've been
perfect.
talking about is when it gets too high and it's not working as well in the body, then it starts to cause some problems. And one of them that you alluded to was with the ovaries, for example. But I think there's quite a few other areas where excessively high insulin levels can cause problems. But you know what? Right now, I think it might make sense to just give a little bit of a. This is something you talked about in the book, where you kind of explained, why do people not really know about high insulin? Why was it not part of the discussion around diabetes? And so, like, why does this seem like such a foreign concept, even though in some ways it's so like fundamental to a common health condition like diabetes?
Right, right. I believe there are two reasons why we persist in having, and why it even began this way, a glucose centric view of metabolic disease, rather than what I contend should be the case, which is an insulin centric view, and that's due to history and science. Historically, the most obvious sign of diabetes was the excess production of urine. That's what diabetes means. Diabetes means polyuria. In other words, producing a lot of urine. And that high urine production is directly a result of high blood glucose. Now, these ancient philosophers, scientists, physicians, they couldn't measure glucose in the blood, but they could taste some alteration in the urine. And it had an altered taste, which is why the real name for diabetes, the full name rather, is diabetes mellitus, or sweetened urine. Glucose doesn't taste very sweet, but I suppose what was most obvious is that animals, dogs, and flies would come and want to lick that urine up because of all the glucose that was in it. And so they knew something was there. So historically, the most obvious manifestation or sign of the disease was because of the high glucose in the blood, causing high urine production, because the glucose spills from the blood into the urine and into the kidneys, going into the urine, and that pulls a lot of water with it, and so the urine production goes up dramatically. And then scientifically, it wasn't until just a handful of decades ago that we could measure insulin at all. We've been able to measure glucose for well over 100 years. And so there were scientific hurdles to measuring insulin. And even now, though, that we can measure it as easily as we can, it still involves taking blood at a clinic and then the clinic sending it to a lab. And so it goes through that multi-step process that involves multiple characters. In contrast to glucose, people can prick their finger and get their glucose levels immediately. I'm wearing a little device on the back of my arm that can tell me my glucose levels every minute of the day. And it's scientifically easier to measure glucose than it is to measure insulin. So collectively, historical precedent and sign and symptom, as combined with the scientific ease of measuring glucose, it's somewhat forgivable. Not somewhat. It is forgivable that we've focused on glucose for so long. But the more
Mhm.
we're learning about insulin and the dynamics between the two, it's becoming less and less forgivable. Case in point, if we have these two variables, glucose and insulin, we've always been tracking the glucose. In fact, indeed, every year the patient comes in and we measure glucose. We measure glucose again and again and again. And we say, well, you're getting hypertension, you're getting infertility, you're having migraines. But we don't think of there being any metabolic connection because the glucose is normal. But if we were to take a step forward, I could say, and measure the insulin, what's
Right.
happening is that we see the insulin climbing for decades, 10 or 20 years before the glucose ever changes. And then eventually the glucose changes. But because we don't look at the insulin, which nowadays is not very forgivable, it's easy enough at a clinic. We measure the insulin and we can detect the earliest signs of this metabolic disarray. We know they've gotten off the healthy metabolic path and are now on the wayward metabolic path. And again, glucose can't tell us that when they've taken those first steps off. By the time glucose changes, they've been on the wayward path for years, decades perhaps.
Yeah, well, there's a lot to unpack there. So, but so first of all, like historically, you were saying that diabetes was kind of first recognized through other signs and symptoms, obviously besides high insulin, because nobody had any idea what high insulin
Right.
was.
Right.
And so in the beginning, it was kind of like, oh, you're peeing a lot
Mm-hmm.
and it's sweet.
Yep.
And I've heard stories about like medical school a long time ago. People or the doctors used to like taste the urine to see
Yeah.
if it was
Right.
sweet. I don't know how often they did that in real life, but you hear about that sometimes.
Right. It's the
So
stuff of legend, regardless.
right. So the diagnosis of diabetes long ago was you had a lot of sweet urine, and then the three P's of diabetes. It's the polyuria that you said, and the polydipsia and polyphagia. We learned this in medical school or
Yep.
PA school and whatnot. And the other ones mean that you're drinking a lot and eating a lot.
Mm-hmm.
So you get thirsty because you're peeing all the time. So that's kind of the history of diabetes. And then eventually people learned how to measure the blood sugar. And so they started tracking the blood sugar and kind of basing everything on that. And then more recently, we've kind of become able to measure insulin. Now, I've actually never had my insulin level checked because I don't go to the doctor that often and whatnot. I'm sure if I went now for a checkup, I might ask them to do it.
Mm-hmm.
But
Mm-hmm.
I could go check my blood glucose right now while we're on the call because I got a little finger stick glucometer. So
Yep.
yeah, so like you said, it's so much easier to check your sugar, but the insulin. You said that the insulin will be high decades or 10 or 20 years
Mm-hmm.
earlier.
Mm-hmm.
So to put that in perspective, if you have somebody who develops type 2 diabetes, the more common type, um, and then we have all these people that have pre-diabetes. Like I see that every day on the
Yeah.
days when I work at the hospital. I have pre-diabetes or I'm borderline or whatever. So they're like trending towards diabetes. Super common. But these people, they don't worry too much about it because they're just borderline, right? It's like, oh, I'm just kind of, it
Mm-hmm.
could get risky, but it's not too bad. Is kind of the way they probably think of it because it's just, oh, I'm getting there. But it sounds like in pretty much 100% of the cases, those people already have excessively high insulin levels to a degree that is probably causing some harm to their body, some pathology and some different problems. Would that be accurate?
Yes. Yes. 100%. By the time they're pre-diabetic, so their insulin's been high for a long time, and now they're becoming so resistant to their insulin that even though it's dramatically elevated, it's not able to clear the sugar from the blood very well. Now the blood sugars are starting to climb, and it gets to here, and they say you're pre-diabetic, and then it keeps going, 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 and then they say they're outright type 2 diabetic.
Yeah, yeah. So, so I don't know if this is the right time to bring this up, but but what's your opinion on how if you get to type 2 diabetes and then you supposedly try all the other interventions like lifestyle and whatever, they'll put you on different medications, usually starting with metformin,
Mm-hmm.
which seems to be beneficial overall.
Mm-hmm.
But then if it
Yep.
gets more out of control, then one of the interventions that we do is we prescribe insulin to people. So here,
Mm-hmm.
your blood sugar is too high, so go ahead and inject some insulin. But from what
Yep.
you're saying, it sounds like the insulin level is already too high, and when we inject insulin, we're adding even more insulin. So, so I don't think that that's something that a lot of medical practitioners kind of connect.
Yeah.
They don't really connect the dots on that necessarily because I didn't, several years ago, I wouldn't have really realized that what we were doing with that. But what's your opinion on that? Does it make sense to prescribe insulin to type 2 diabetics? And if not, what should we be doing instead?
Yeah. So back to my acting this out. By the time the person, so insulin it has become diabetic, it's gone through this sort of progression. Insulin has been high for a long time. Glucose levels have been climbing, climbing, climbing. In some type people with type 2 diabetes, the insulin will drop a bit, which accelerates the glucose even more. Or other instances, it stays high and the glucose just still relentlessly climbs onward. In true type 2 diabetes, what many people think happens is that the insulin comes up and the glucose comes up and then the insulin goes to zero and then it skyrockets.
Hmm.
This is how so many people view type 2 diabetes. Even very trained individuals believe that it's like type 1 diabetes, which is a true deficiency of insulin. Now, there are some people who have had type 2 diabetes who coincidentally develop type 1, which is an autoimmune disease and has nothing to do with type 2. I don't even think they should be given the same name in the
Hmm.
same family of diseases because they're both diseases of opposites. Whereas type 1 diabetes is a disease of too little insulin, type 2 is primarily a disease of too much, or at least that's what's driving the disease. Regardless, even if insulin has come down a little bit in the person with type 2 diabetes, accelerating the spike in glucose, it's still significantly higher than it used to be before they ever started on that wayward metabolic path. But regardless, because we have a glucose centric view of the disease, essentially the clinician is saying, well, to heck with your insulin. Who cares if we push it up even higher? They might not even know where it is. All they know is if they push the insulin up even higher, the glucose will in fact come down. And because that's the target, the glucose, they believe they're achieving the optimal outcome. However, it's much more complicated and sinister than that. The more aggressively we're giving the type 2 diabetic insulin to control their glucose, the faster we kill them. They are 3 times more likely to die from heart disease and twice as likely to die from cancer and twice as likely to develop Alzheimer's disease. And throughout all of it, they need more and more and more insulin because they're becoming ever more resistant to it. So in the book, I use this analogy, and it's quite heavy-handed, but it's illustrative, and that is giving insulin to a type 2 diabetic is analogous to giving an alcoholic another glass of wine, hoping it will solve the problem. You're giving them more of the very thing that caused the problem, because the truth is, too much insulin is one of the primary causes of insulin resistance.
Yeah, yeah. So, yeah, again, a lot going on with what you explained there. So part of that is the nerdy science stuff, which is, that we could draw graphs of the insulin, like how high is it when you get type 2 diabetes,
Mm-hmm.
and once your type 2 diabetes gets worse, if it gets worse as it progresses, at is the insulin even higher, or does it start to drop off? And there's a little bit of variability there, I guess, because you said
Mm-hmm.
like occasionally it'll drop down, or that person will coincidentally develop the autoimmune type 1 diabetes.
Yep.
That's probably the minority, to say the
Yep.
least.
Very uncommon. Yep.
but but it sounds like in the vast majority of cases, people with type 2 diabetes still have excessively high insulin, even when they're when it starts to look like their diabetes is so out of control that you quote unquote need to prescribe them insulin. And to be fair to the medical practitioners, in school, I don't think it's caught on yet. Maybe now, maybe in 2022, if you went to a medical school class, then maybe they're talking about measuring insulin levels and taking that into consideration with
Yeah.
with the treatment. But certainly, when I went to school, we were not taught anything like that, and so it was really you just kind of learn that, okay, eventually, if it gets out of control, then you'll have to add on insulin. If nothing else is working, if quote unquote
That's right.
nothing else is working, but there might be something else that could work. But yeah, so before we get into more like what to do, kind of what to do if you have diabetes, for example. What are can you give me kind of a brief rundown of how insulin resistance connects to other health conditions besides diabetes? Because from what we've been talking about, obviously type 2 diabetes is having excessive insulin, and that's like the main problem. And people are familiar with the fact that people with diabetes will often inject insulin. So that sounds a little familiar, even to the lay person. But what other medical conditions or health conditions is having high insulin connected to, and why?
Yeah. Yeah. In fact, the list is long. And that's why, I sort of use a whole portion of an entire book to devote to it. But just to highlight
Right.
maybe some of the more relevant ones, we could go sort of top to bottom, where Alzheimer's disease is very commonly referred to nowadays accurately as insulin resistance of the brain. In Alzheimer's disease, we know that there is compromised glucose use in the hippocampus. The hippocampus is the memory and learning center of the brain. And the hippocampus, like most of the structures of the brain, uses two fuels. It meets all of its very high metabolic rate demands from glucose and ketones. And everyone's heard of ketones because everyone's heard of the keto diet. Probably very
Mhm.
misunderstood, but nevertheless, a ketone is a molecule that circulates in the blood when we're burning a lot of fat. Essentially, when insulin is low, it in fact directly comes from fat. When we start cutting up fat molecules to burn them, some of those turn into ketones. So, regardless, those are the two fuels of the brain, glucose and ketones. Well, glucose needs some insulin to work in order to get into the hippocampus to fuel it, to give it its energy. Well, the hippocampus can become insulin resistant, like so many other parts of the body. And now it has a demand for this much energy, but because it's insulin resistant, it can only get this much from glucose. But most people, because they have chronically elevated insulin, have essentially no ketones in their blood. Because you would say, well, if the hippocampus or the brain can't get all this energy from glucose use is down here, well, then let's just have ketones fill in the rest. Well, easier said than done. Again, most people don't have enough ketones to fill that gap because their insulin is elevated all the time because they're eating starchy, sugary foods all the time. But it works. The limited evidence, the pilot evidence we have, shows that if you can fill that energetic gap to allow the brain to meet its full metabolic demand, then you do improve cognition. Now, I'm not saying you cure the Alzheimer's. No, that's irreversible, but you do improve it. There are tests to show that the people who do this, they think better, they speak better, and they can perform daily actions better, like getting dressed, for example. So, Alzheimer's disease is one of the more sobering examples of what insulin resistance can do, in this case, the brain. Also, to a small degree, Parkinson's disease appears to have some relevance or some connection to insulin resistance, insofar as insulin alters the production of dopamine from those specific neurons that get destroyed in Parkinson's disease. And then as we start to move down briefly, with heart disease, one of the leading causes of heart disease is hypertension or high chronically elevated blood pressure. And insulin resistance drives blood pressure through several totally distinct mechanisms. And in so doing, is really the primary cause of insulin resistance. And indeed, people with hypertension who improve their insulin resistance find that their blood pressure problems, their hypertension is resolved often within days. It's an exceptionally fast response.
Mhm.
And then one other one is the liver. Fatty liver disease is the most common liver problem. Insulin resistance drives the production and accumulation of fat in the liver that high insulin does, the hyperinsulinemia. And then lastly, perhaps fertility, where in women, I already noted the connection with polycystic ovary syndrome. And even in men, the most common fertility issue is erectile dysfunction. And much of the problem, or at least part of the problem, is that insulin can't work properly. Normally, insulin will act in the blood vessels to create something called nitric oxide. And the nitric oxide will cause something called vasodilation, or in other words, it will open the blood vessels. And as the blood vessels open, a man can experience normal erectile function. However, as the blood vessels become insulin resistant, now insulin cannot induce or cannot cause that vasodilation. The blood vessels stay constricted when they should be opened or dilated, and the man experiences erectile dysfunction.
Yeah, that's a pretty good rundown because I think anyone listening can relate to at least one of the things you talked about. Either they have family members with dementia, like Alzheimer's, or they know someone who had a heart attack, or it runs in their family, or they're worried about having a heart attack, or they know people who have fertility problems, which are very often related as well to having high insulin. So, yeah, so there's a lot going on there. Um, I I heard you on another interview mention a few ways that someone can kind of detect. So detect if they have high insulin. Now, if you have one of
Hmm.
these medical conditions like high blood pressure or polycystic ovary syndrome, then there's a pretty good chance you have high insulin. So that's
Yes.
one thing. But what are some like practical ways that somebody can maybe tell just by looking at their own health or their own body if they likely
Right,
have high
right.
insulin?
Yeah, yeah. So that's a great question. I'm glad for the chance that you're bringing this up. One way is to look at the skin. I like to joke that the skin is the window to the metabolic soul, and there are two very almost just rock solid things people can look for that would be proof of insulin resistance, and they can both happen right around the neck. So these can be pretty obvious. Alternatively, they can happen around the armpits or in the groin, not quite as obvious. But the signs are the same regardless. One is this condition called acanthosis nigricans, which are large. And these are not small, subtle things. They're not like my freckles, for example, teeny little marks. They're large, kind of swaths of dark, kind of velvety, rough, well, that altered texture of the skin. It's not the typical smooth texture, it has an altered texture, and it will be patchy. It'll kind of go along the skin and even be a little kind of crinkled, wrinkled. At the same time, in the same place, a person can experience skin tags, and that's these little. It's these almost little like columns or pillars of skin just growing straight up like a little mushroom. It's not like a little hill like a mole might be. It's not even discolored. It's generally the same pigment of whatever the skin color is, but it's these little projections, these little stalks or columns of skin. They're both very strong evidence of insulin resistance, how insulin is altering the skin cells. And thankfully, they're all very reversible as insulin resistance is improved.
Okay. So, in addition to like the medical conditions you might discover through other means, like the blood pressure that's high, then there's some skin things. So the skin tags, which are like the
Hmm.
mushroomy things that grow off,
Hmm.
and then the dark, rough areas as well in some cases.
That's right.
Yeah. Okay. So, um, so why don't we kind of shift into? So I think we've really hit on a lot of important factors of like, how do you know if your insulin is high and what medical conditions are associated with that? And I think most people realize that diabetes is super common, and so it's certainly something that's important for a lot of people to know about. But why don't we shift a little bit into some practical tips or strategies, um, and kind of an 80-20, like I'm going to ask you about a few categories, and maybe you can tell me what are the most impactful things that someone could do if they either have prediabetes or diabetes, or they have one of
Hmm.
these other medical conditions, or Alzheimer's runs in their family and they're going to try to prevent that. So that's
Yeah.
kind of the lens we're looking through, but certain things that people can do. So we'll start with the big one, which is nutrition. I mean, I think it's the big one.
Yeah. Yeah. Same.
um, what is your kind of the top few things that you think somebody could do that would have the biggest impact if they're trying to either fix or prevent one of these kind of medical issues related to high insulin?
Yeah. Yeah. In my mind, there are four pillars of addressing nutrition in such a way to improve insulin sensitivity and lower insulin levels. And the first is control carbohydrates. And by that, I mean, don't get your carbohydrates from bags and boxes with barcodes. That's chips, crackers, bread, cereal. So I'm not declaring war on all carbohydrates, but rather focus on fruits and vegetables. Eat them, don't drink them. Don't make juices or smoothies out of them. So that's rule number one: control your carbohydrates, because as you eat those starchy foods, your glucose levels will spike, and then your insulin levels will spike, and it takes a long time for them to get resolved to come down. And by the time they're coming down, most people have spiked them back up. The second, prioritize protein. Make sure you're eating enough high quality protein to retain all your lean mass and to promote satiety. Protein's very filling. Third, I say is kind of related to number two, which is don't fear fat. A lot of people are, of course, nowadays afraid of fat because of the caloric content. My view is whatever fat comes with protein, eat it. Enjoy it. It's supposed to be there. They're supposed to come together. Don't try to get rid of the fat that's coming with the protein that you're prioritizing. And with regards to fat, I have a very favorable view of animal fat and fruit fat. That's the fat that comes from coconuts, avocados, and olives, the flesh of those fatty fruits, not the seeds that we nowadays extract oil from, like soybean oil or corn oil or so-called vegetable oil. It's not vegetable. There's nothing vegetable about it. That's just a clever marketing gimmick. They're from seeds and they're all refined, and they should be heavily, heavily avoided. And then the last one is fasting. We have to step away from the incessant eating where we nowadays are in a culture where people are eating every 2 hours. That is just, it's bonkers to think that's healthy. It's bonkers to think that's how we were built to eat, or that we've ever eaten like that in human history. We should eat much less frequently, including deliberate fasting periods. And that can be any number of ways, but certainly an adult should be able to go through a 24-hour fast from time to time.
Gotcha. Yeah, well, that's a lot of good tips. So see if I can recap. So you talked about controlling the carbohydrates, especially the processed ones that come in a box with a barcode, like the crackers and the chips and things like that, because they're going to spike the blood sugar, and I guess they're going to kind of spike the insulin as well, and over time cause that to get higher and higher, and lead to insulin resistance. You talked about prioritizing protein, so getting decent quality protein in your diet because it'll keep you satisfied longer. And obviously it's good for building muscle and things like that as well. And then not fearing fat, particularly fat that comes naturally with other foods, like in the meat, fish, poultry, even something like cheese, where it comes together with protein. And then you talked a little bit about different types of fat. So I think most people still don't really know. It's only the people I think that have dived into like just learning a lot about nutrition and stuff in the last few years that are really familiar with this concept of the vegetable oils and the seed oils being harmful. Can you just briefly elaborate on where are these oils? How can we avoid them? Why are they harmful? Where are they, and how can we avoid them?
Yeah. So they are in almost everything we eat. Soybean oil, in particular, has become the single most common source of fat calories in the human diet. So the average person today on the planet will get most of their fat from soybean oil, and that's because most of their fat is coming from processed foods. Soybean oil and it's like the other ones, like safflower or cottonseed or canola. They're all kind of variations of the same theme. They're in every processed food. And I can only speak to what in my specific area of expertise, although there are others who would speak on other aspects of the harms of soybean oil with more authority than me. But the primary fat in these oils is a fat called linoleic acid. And linoleic acid, we're eating tens of thousands of times more of it than we ever have in all of human history. There's nothing comparable. We eat more. People would say, well, we eat a lot more sugar. Yeah, but not 50,000 times more sugar than we did 100 years ago. So this is something that went from essentially zero, being a very modest part in natural fat sources. Like all animal fats have a little bit of linoleic acid, but it's very little. Now, of course, to being the main fat we eat. But linoleic acid, one of its metabolic fates is to turn into a molecule called, the abbreviation is 4-HNE. 4-HNE is a molecule that can accumulate in cells and fat cells in particular. And when it's accumulating in fat cells, it will force fat cells to grow through a pathway or to grow through a process called hypertrophy. And so this is when each individual fat cell is expanding. This is a problem because as the fat cell expands, it eventually reaches a point beyond which it is reluctant to grow. And then it starts to become very, very resistant to insulin. And it's leaking free fatty acids into the bloodstream. At the same time, it's becoming very pro-inflammatory, and it's leaking pro-inflammatory proteins, promoting inflammation throughout the body. And the combination of those things is quite a wicked one, and they start promoting insulin resistance throughout the rest of the body. So to bring that all back to the origin here, too much linoleic acid results in the accumulation of 4-HNE in fat cells, which make fat cells inflamed and very fat, ultimately promoting insulin resistance throughout the body.
Gotcha. Yeah. So thanks for that explanation. And that starts to teeter on the edge of the the overly scientific stuff that I know a lot of people
Yeah.
might have a hard time wrapping their heads around. But uh, eh, no offense, obviously, it's good to get that
No,
explanation. I'm
I
just
none
kind of
taken. Yeah.
thinking like the listener or whatever. But to kind of summarize again some of those nutritional points that you made. So it's better if people don't fear fat, but there are some good types of fat and some bad types of fat.
Yep.
And you,
Just like there are, good carbohydrates and bad
mhm,
carbohydrates, for example.
yeah, you emphasized better fats coming from animal sources as well as fruits, meaning
Mhm.
people don't usually think of fruits as having fat, but I guess we're talking
Right.
about things like avocados, olives, coconut, and some of the oils that come from them as well.
Yep. That's
And I'd
right.
maybe throw in like nuts would be another
Hmm.
good broad category as well. Um, and then the bad fats, which, or at least they seem to be pretty harmful. They're a new concept. Humans never ate these that much before, and we're eating tons of them. It's the soybean oil, the canola oil, some of these other vegetable oils or seed oils, and they're usually very processed, refined, heated, and have some other secret ingredients like these solvents or whatever.
That's
That,
right. And
that
deodorants. Yep.
yeah. So that's the thing about the fats, and then just like you said a moment ago, the carbs, similarly, there's like good carbs and bad carbs to some extent. Like, so the better ones might come from vegetables, for example, whereas the bad ones are these highly refined, ground, crushed up kind of things that you buy in a package at the store, generally
Yeah.
speaking.
Yep.
Generally speaking. So those kind of nutritional changes are probably a huge and foundational change that somebody could make if they're trying to improve insulin resistance, or if they have prediabetes or type 2 diabetes and they don't want it to get worse, or obviously if they want it to get better, or any of
Hmm.
these other related medical conditions that are also related to insulin resistance or high insulin, like high blood pressure, polycystic ovary syndrome, your risk level for getting dementia later on, because usually you're not going to see that right away, but it
Yeah.
might be later in life for most people, depending on what age they are right now. Fatty liver would be another one. So all of those things, if somebody's dealing with those and they want to change, I think that's a really good start and a good foundation. We don't have a lot of additional time to talk about other things that people can change, but maybe you can give me just a few kind of quick pointers on a few other categories. Um,
Yeah.
so what, or maybe I should just open it up to you in the sense that other than nutrition, what are the biggest, most impactful changes that somebody can make to try to combat high insulin or insulin resistance?
Hmm. Yeah, yeah. So there are a few primary causes of insulin resistance. One is chronically elevated insulin, and that is superbly addressed by the dietary tips I just gave a moment ago. The other two causes, primary, that I consider of insulin resistance are inflammation and stress. With inflammation, it's very difficult because if someone has an autoimmune disease, the body's more inflamed and thus will be more insulin resistant. That happens, and so that's a difficult one to really address and have a kind of strategy on. The other one, stress, is better, where we know that elevations in stress hormones, namely cortisol and epinephrine, also called adrenaline, those are hormones that will cause insulin resistance in humans. And now someone would say, well, great. How do I control my stress? The easiest way to control your stress hormones is to do your very best to sleep well. If someone can sleep well, their stress hormones are significantly lower the following day. And my tips for sleeping well, my biggest, everyone talks about blue light. Yeah, that's probably relevant.
Hmm.
I don't know much about it. But for me, if you can go to bed on a relatively empty stomach, with relatively normal glucose levels, in other words, at least a few hours after you've eaten, and what you ate wasn't just pure starch and sugar, then you will sleep so much better. When you go to bed with a very full stomach and high glucose levels, you have activated your sympathetic nervous system. And that means your heart is going to be beating. Well, those stress hormones are causing this. Your heart is going to be beating harder and and faster, and your body temperature is going to be elevated. So you're warmer and you're lying there feeling your heart pounding in your chest, and you're wondering what on earth is happening. And all you know is that you're not sleeping well. Well, try going to bed on a relatively empty stomach with relatively normal glucose levels, and I can guarantee better sleep.
Yeah, that sounds like a great tip, because there are other things that we could talk about related to stress, obviously, and sleep. And sometimes it can be a vicious cycle for people. It's like if you're stressed, it's hard to sleep. If you don't sleep, you're more stressed,
Yep.
and all that good stuff. But there's a very practical kind of just workmanlike thing that you can do, which is be done eating at least a few hours before you go to bed. And that goes along with time restricted eating, which people also call intermittent fasting. If you don't snack after dinner, for instance, and you have dinner early-ish, not like right before bedtime, then that kind of accomplishes that right away. And I've certainly noticed sometimes that my body seems to be working harder, and maybe it's because I have a full stomach, and it's pumping all this blood to my stomach and to my intestines and all this stuff. And there's other indirect effects, but that's just what I can kind of sense as I'm laying there in bed. And I think on top of that, of course, it could be helpful for people to, try to avoid their phones at night, not so much because of the blue light, but because of all the media that hypes them up, whether that's social media or other things. And I've heard a lot of tips recently about, if you get your diaphragm moving up and down, either through deep breathing or laughter, that like helps lower stress hormones. And so there's a lot of other things that people can do, avoid the media consumption, also to stop working by a reasonable time, right? Because I know my brain is like on overdrive sometimes if I'm still thinking about work related stuff. So those are just a few things I've been thinking about recently as well that are kind of related to that same topic. But I like how you gave a very practical tip that it's not like, it's not hard to measure. Some of these things are hard to measure, but it's easy to measure. Okay, did I give myself at least 3 hours after I stopped eating before I went to bed, so I can do most of my digestion before I go to sleep? So that's good. So what about exercise? Does exercise play a big role in fixing insulin resistance, and how does its impact compare to things like nutritional changes, including fasting, but also other nutritional improvements, or sleep and stress management?
Yeah. Well, exercise is very important. I wouldn't put it on par with nutrition. Nothing is. That's unparalleled in its efficacy. But I would certainly put it, maybe shortly under it, right around the range of good sleep. The benefit of exercise is that during exercise, we don't need insulin to control glucose levels. Our hungry muscles, as they're working out, start pulling in the sugar from the blood on their own. They don't wait for insulin to come tell them what to do. And indeed, insulin goes quite low. And at the same time, glucose is coming down. So exercise, I'm a big advocate of exercise for those reasons. Also, there are very acute, immediate benefits. For example, what I strongly encourage people to go on just even a 10-minute walk after you have eaten your most starchy, sugary meal of the day. This is very well quantified or measured that if you have that starchy, sugary meal, in the absence of exercise, there's a pretty considerable increase in blood glucose and insulin levels. If you, at the end of that starchy, sugary meal, go out on a brisk walk, you can lower that increase by about 50%. It's really a rather dramatic reduction in the blood glucose and the insulin levels. So it's an undeniable and very effective intervention to try to mitigate some of the metabolic disarray that comes from indulging in very starchy, sugary meals.
Yeah. So would you say that it's more impactful to exercise, meaning like going on a walk, not necessarily intense exercise? Is it more impactful to exercise after a starchy meal, or can doing it before the meal have a similar impact?
Yeah, that's a good question. The benefit is at the end of it most pronounced. Now, I would consider these to be two different types of things, though, where to me, we can call a brisk walk exercise, but I would just say that's just kind of baseline minimum, what you ought to be doing.
Mm-hmm.
Ideally, a person does that after their most starchy meal of the day, but they have a separate time of day where they're deliberately and very explicitly trying to challenge their muscles to help them grow. Now, that doesn't mean we're all doing deadlifts, and pull-ups, but it does mean that we're challenging the muscles in some way or another, just to help the muscles stay big and strong.
Yeah, that makes a lot of sense. I think about it sometimes in the context of the blood sugar, like you said, with the walking, uh, because I guess when you exercise, you get this, like you said, insulin independent changes that cause more sugar to be taken into the muscles.
Mm-hmm.
And I think that's through that more of the GLUT4 transporters come into the muscle.
Yeah, well, now
Now,
look who's getting too technical, Ben.
sorry, it's just something I'm curious about. Yeah, but you're right. You're right. But I don't know how long those receptors stay there, or those transporters, I guess I should say, not receptors.
Yeah.
How long they stay. So, say if I did an intense exercise and workout right now, or I finished right now, and then I ate something 10 minutes or 30 minutes from now, like how much of an impact those would still have. I don't know if you if you know anything
Well,
about the
the
timeline or whatever.
GLUT4, yeah, we are getting technical, but you're the one you started it.
Yeah, that's
So
true.
GLUT4 will cycle in and out of the membrane very, very quickly. Within just a handful of seconds, it's opened, and it's gone back in, and another one has come and opened. The effect, depending on the intensity and the duration of the exercise itself, but the GLUT4, the hungry muscle effect, can last for probably 30 minutes or so after exercise. However, that is sometimes countered by the gluconeogenic effect of the exercise. In other words, when the person starts exercising, especially if they're exercising in a fasted state, the muscles are consuming a tremendous amount of glucose, and the
Mm-hmm.
liver starts releasing a tremendous amount of glucose to feed the muscle. So depending on how intense the activity has been and how quickly we stop, in other words, kind of a modest cool down, we can actually see what had been a very low glucose during exercise spike quite readily, and then drop back down quite readily. But that's because there was just this brief mismatch that the muscles stopped consuming a lot of glucose, but the liver was still releasing it. And then the liver gets the message, okay, wait, we're done. All right, I'll stop. And then the muscle slowly clears through all that excess glucose, and we go back down to normal.
Very interesting. Very interesting. So basically, when you exercise, your muscles suck up more sugar, suck up more
Mm-hmm.
glucose. And so it's especially helpful after you eat that starchy meal to at least go on a walk or do anything to move around. And
Indeed.
that is interesting about the workout, how your muscles are sucking up sugar. And so your liver starts making more sugar. And then there can be a little lag, and you get a little leftover sugar at the end or something. But
Right.
um, for the sake of time, I guess we'll need to wrap up. But what if people want to learn more from you? I did mention your book at the beginning, but if people want to learn more from you, where would you like them to go?
Yeah. Thanks again, Ben. This was great. So people can find me on two venues, two avenues where we can connect. One is primarily on Instagram. I'm generally active on that. I try to do about a post a week, and it's not me working out or me eating food or smiling, making peace signs with my fingers. It's always little video clips about human metabolic function. I try to make it very relevant in that regard. And then in addition to that, I encourage everyone to find me at my other website, Get Health. And health is spelled HLTH, gethealth.com. And there is regular blog content that we provide there, and with regard all surrounding metabolic function in humans. And people can also learn about a low carb meal replacement shake that I developed, and people can go there to learn more about it.
Yeah, yeah. And I have tried those shakes, and I find that from what I can tell, they seem to be probably the best formulated meal replacement shakes that are out there in terms of helping to fix some of these medical issues we're talking about, like the insulin resistance and stuff like that. So great. I'll put links to that stuff in the show notes. And Thanks a lot for your time. I really appreciate your expertise. And I know there's a lot of valuable information that if people put it in practice, that will make a big impact in their lives.
Well, my pleasure. But I agree. I think this has been time well spent. Hopefully hopefully everyone listening has found some nuggets they can take away and improve their own health. Thanks again for inviting me.
Yeah, sure. And I'd love to have you back sometime, but we can
My
talk about
pleasure.
that later. So.
Yeah.